This continuing education unit event is on implicit bias, health disparities, and health equity, improving equity across Michigan's healthcare systems. The objectives for this lesson are as follows: to explore how implicit bias fits into the larger picture of prejudice and bias, to review data demonstrating the impact of implicit bias on health and healthcare, to examine strategies to mitigate and reduce implicit bias, to understand implicit bias and identify strategies to reduce bias to improve health disparity within healthcare systems and within care of an individual, to recognize situations that magnify stereotyping and bias and develop strategies to correct them, and finally, to improve understanding of the religious, social, organizational, and cultural backgrounds. Most of you are aware that the state of Michigan now has a mandate. The mandate is to improve equity across Michigan's healthcare systems. The governor issued an executive directive on July 9, 2020, directing the Department of Licensing and Regulatory Affairs, known as LARA, to develop rules that require implicit bias training as part of the knowledge and skills for licensure, registration, and renewal of licenses of health professionals in Michigan. This event will meet the required LARA mandate. So first, let's talk about the definition of what implicit bias is. So first, think about what is bias. Bias consists of attitudes, behaviors, and actions that are prejudiced in favor of or against one person or group compared to another. And then what is implicit bias? It's a form of bias that occurs automatically and unintentionally that nevertheless affects judgments, decisions, and behaviors. Research has shown implicit bias can pose a barrier to provision of health care nationwide. So implicit bias is also known as unconscious bias, the bias in judgment and/or behavior that results from subtle cognitive processes, such as implicit attitudes and implicit stereotypes, that often operate at a level below our conscious awareness and without intentional awareness. So what is the impact of bias on health and healthcare? Exactly what is the problem? In the 1990s, hundreds of research studies are published documenting the health disparities among various populations in the U.S. Then in 1999, Congress asked the Institute of Medicine, known as IOM, to assess the extent of racial and ethnic disparities in healthcare. This led to several milestone publications. The first is Crossing the Quality Chasm from IOM in 2001, which identified healthcare systems did not meet the needs of our diverse nation. Then in 2002, Unequal Treatment from IOM confronted ethnic and racial disparities in healthcare. In 2001, the U.S. Department of Health and Human Services published standards of care that are culturally and linguistically appropriate to address inequities in healthcare services. And then from 2002 to 12, the class standards were enhanced and addressed how to embed into care to address inequities to improve the quality care in underserved population. Also in 2001, IOM published In the Nation's Compelling Interest, which noted the U.S. becoming more diverse and healthcare providers and clinicians needing to also be more diverse. And in 2011, the Health and Human Services Action Plan stated to reduce health disparities with evidence-based strategies and goals for healthcare systems to engage and create momentum. In other words, it was a call to action. And then in 2020, when COVID hit, this highlighted the continued impact of implicit bias and disparities on health and healthcare, as the virus occurred at a much higher rate in those of color. Also notably is differences in the healthcare workforce diversity. Increasing the diversity of the healthcare workforce is essential for the adequate provision of culturally competent care to our nation's most burgeoning minority communities. As you can see here, our clinicians are not very diverse, as only 15% are clinicians of color. And there's also less diversity in providers, where only 9% of providers are of color. This includes MDs, DOs, nurse practitioners, and physician's assistants. So why does this actually matter? The U.S. population is becoming increasingly diverse. It's important to consider how diversity can affect the way that healthcare services need to be adapted to meet various social, cultural, and linguistic needs. Recognizing and appreciating these differences allows clinicians to effectively and empathetically provide the best care to a diverse population. But why should we be concerned? In 2015, racial health disparities are associated with substantial annual economic losses nationally, including an estimated $35 billion in excess healthcare expenditures, $10 billion in illness-related lost productivity, and nearly $200 billion in premature deaths. Health disparities are often considered to be a racial or ethnic issue, but people are subject to unconscious bias based on many factors, including sex or gender, sexual identity, socioeconomic status, education level, age, disability, obesity, and geographic location. Bias causes healthcare disparities in both healthcare systems and in individual care. There's a cause and effect. So bias leads to disparities in care. African Americans are more than twice as likely as whites to die of prostate cancer and nearly twice as likely to die of stomach cancer. Hispanic and American Indian Alaska Native women have higher rates of cervical cancer than women in other racial ethnic groups. Here's a conceptual model which shows the influence of implicit bias. Here's an example. How does bias influence a health system, and how does it bias influence of an individual's care? You have the clinician with their own implicit biases and background and experiences, which both influence their behaviors and judgment. And then there's the clinician encounter, where you have the person's perception of the clinician, medication intensification and adherence, visit adherence, and probably issues with hypertension control if their own perceptions do not impact how to influence the care of the participant. And then you also have the participant's own implicit bias, their background experiences, and their behavior and the judgment. So in between the clinician or a provider's bias and the person's bias and background experiences, there's perceptions which can influence both, in this example, medication intensification, adherence, attendance at doctor's appointments, and ultimately hypertension control. So there's 3 ways bias can cause disparities in healthcare. First is persistent discrimination, which can lead to physiological or psychological stress. The second is clinician implicit bias, which can lead to disparities in clinician decision-making, which can lead to healthcare disparities. And the third is clinician implicit bias, which can again lead to disparities in clinician decision-making and can lead to a negative reaction from an individual, which can lead to healthcare disparities and all ultimately can impact disparities in health. So here's what the definition of disparities are. Health disparities are differences and/or gaps in the quality of health and healthcare across racial, ethnic, sexual orientation, age, religion, and socioeconomic groups. Disparities can cause differences in disease, health outcomes, or access to healthcare. There's first disparities in health status. Higher rates of health status in some races, such as higher rates of hypertension in African Americans. Or disparities in healthcare where there's differences in preventive, diagnostic, or treatment to certain races or ethnicities, and includes accessibility and quality with providers where there's failure to act with certain groups, such as vaccinations, treatment of pain, or infant mortality, as well as many others. So this is an example of a comparison of blacks versus white adults. On the left-hand side, you'll see the blacks have 14% fair or poor health status compared to 9% for those who are white. There's also a difference in obesity, with 39% in blacks and only 30% in whites. Also in diabetes, where 11% of blacks have been told by their doctor they have diabetes, while only 7% of those who are white have. And also in regard to asthma, where 12% blacks have been told they have asthma and only 10% whites. So across these 4 disease conditions, you can see that those that are black have a higher level of disease than those who are white. This data comes from selected health conditions among non-elderly 18 to 64-year-old adults. All of these differences have been shown to be statistically significant difference. There's also disparities among American, Indian, Alaska Native compared to whites. Again, you'll see there's 17 to 9% difference in fair or poor health status. There's also worse physical limitations, with 37% having physical limitation compared to 32% whites. There's also a 10% higher rate of obesity, 40% compared to 30% white. They also smoke at a higher rate at 31% compared to 20% of whites. Asthma is also worse at 15% compared to 10% with whites, and diabetes 14% compared to 7% in whites, and substance abuse use or disorders 15% compared to 10% in whites. Again, all of these are statistically different. There are also disparities among Asians versus Native Hawaiian and other Pacific Islanders compared to whites. As you can see, problems with paying medical bills is at 9% in the Asians, 23% in the Native Hawaiian and Pacific Islanders, and 16% in whites. Regarding fair or poor health status, Asians are 6%, Native Hawaiian are 12%, and whites are 9%. Regarding asthma, Asians are 8%, Native Hawaiians are 19%, and whites are 14%. Regarding diabetes, Asians are 6%, Native Hawaiians are 11%, and whites are 7%. No mammogram in the past 2 years for women is at a rate of 21% in Asians and 22% in whites. And no pap smear in the past 3 years for women is at 31% for Asians, 28% for Native Hawaiian, and 19% for whites. Again, there is a statistically significant difference among these, showing disparities among the different types of races. There's also problems with the cost of health disparities. Combined cost of health inequalities and premature death cost approximately $1.24 trillion a year. The potential reduction in the indirect cost associated with illness and premature death, if minority health inequalities were eliminated, is approximately $1 trillion a year. The potential reduction in direct medical care expenditures, if minority health disparities were eliminated, is estimated at $229.4 billion a year. The percent of excess direct medical care expenditures for African Americans, Asians, and Hispanics that were due to health inequalities is 30.6%. Research shows that implicit bias and healthcare disparities can be mitigated with awareness and effective reduction strategies. To reduce implicit bias, think of counter-stereotypic examples. Identify co-workers of diverse backgrounds in your field. There's also perspective taking. Imagine what it's like to be a person who experiences people questioning your ability or skills because of your social identity. There's also the interruption of automatic bias thoughts. Identify when you may be most influenced by implicit bias, like evaluating performance, and create an action plan, like reviewing the evaluation criteria before assessing each person's performance in the form of if and then statements. This will increase mindfulness of or mitigate the influence of implicit bias. And in education, implicit bias training in a workplace can raise awareness. So what kind of training and awareness works regarding implicit bias? Let's talk about what works and what does not work. While raising awareness of and reducing implicit bias is an important way to improve diversity, implicit bias is only one among many factors. A concerted, integrated approach to increase participation and engagement of underrepresented groups is essential to achieve true diversity and inclusion. The top 3 diversity training approaches used by U.S. companies are the least effective. There's poor return on the usual diversity programs. The 3 most popular interventions make companies less diverse, not more, because managers resist strong-arming. For instance, testing job applicants hurts women and minorities, but not because they perform poorly. Hiring managers don't always test everyone. White men often get a pass and managers also don't interpret results consistently. So here are the 3 most common diversity training programs that are done in most businesses over the past 5 years. And as you can see, mandatory diversity training among Black women has a negative 0.92 impact, and also among Asian men, negative 4.5 and negative 5.4 in Asian women. Job testing has a negative impact on white women, Black men and women, Hispanic men and women, and Asian women. And grievance systems have a negative impact on white women, Black and white women, men and women, Hispanic women, and Asian men and women. So the 3 most common types of diversity training programs, mandatory diversity training, job test and grievance systems, pretty much have a negative impact on improving diversity and implicit bias. Here's what diversity programs actually get results. Companies do a better job of increasing diversity when they forego the control tactics and frame their efforts more positively. The most effective programs spark engagement, increase contact among different groups, or draw on people's strong desire to look good to others. Here's several that are very effective. Voluntary training, self-management teams, cross-training, college recruitment of women and minorities, mentoring, a diversity task force, which seems to have the most impact, and also diversity managers, which also has very high impact. So you can see each type of these diversity programs have great results. So how can we personally improve our implicit bias? Remember, ineffective implicit bias change strategies are mandatory training, job testing, and grievance systems. Where effective implicit bias change strategies include voluntary training, self-management teams, cross-training, recruitment, mentoring, and a diversity task force and manager. Those are the implicit bias change strategies to request in your own work setting. And then you have to think about cultural awareness. What does culture include? It's language, communications, customs, values, thoughts, actions, beliefs, and groups. And how does culture impact healthcare? In the following way: how one receives healthcare information, how one exercises their rights and protection. Also, culture impacts what is and is not considered a health problem, and how one expresses symptoms and concerns about a problem. Culture also impacts who should provide treatment for a problem and what type of treatment should be given. So healthcare clinicians and providers need to have cultural competency to help acquire a stronger self-knowledge and understand their own reactions. They need to work to develop proficiency in working well with people from other cultures and guiding resource allocation for equitable services. Having a firm grasp of what culture is and what it is not, having insight into intracultural variation, understanding religion and culture's important role in personal identities, life ways, and mental, physical health of individuals and communities. Also, being conscious of one's own religious or culturally shaped values, beliefs, perceptions, and biases. Observing one's reactions to other people whose faith or cultures differ from one's own and reflecting upon these responses, and seeking and participating in meaningful interactions with people of differing cultural, gender orientation, or religious backgrounds. All of these approaches can improve cultural competency. Culturally competent care is essential. The culturally competent clinician must develop knowledge, skills, and positive attitudes about diverse cultures to work individually and collaboratively within the healthcare system to promote effective care. Two cultural care theories include Leininger's theory of cultural care diversity and universality, and Campias-Bacot's The Process of Cultural Competence. Here is Campina-Bacot's model. You have cultural knowledge gaining, which then leads to cultural awareness and skills, which can be used when you have cultural encounters, which then all overlaps to become the process of cultural competence. Each factor is important. It's an evolutionary process, coming to know cultures of different types and becoming competent. So culture is the shared assumptions, values, and beliefs of a group of people that result in characteristic behaviors. Cohort cultural beliefs are important. It's risky and often incorrect to assume that every member of a cohort shares the same cultural beliefs. A basic understanding of others' beliefs may help in assessing individuals' beliefs. Cultural and spiritual awareness is being knowledgeable about one's own thoughts, feelings, and sensations, as well as the ability to reflect on how these can affect one's interactions with others. In the African American culture, they may incorporate religious coping and pastors' help in their high self-esteem. Illness may be perceived as due to lack of faith, and they may dislike prescription medications. They may listen attentively to health education or offer alternative understanding. Health may be discussed in family or group settings, but they experience many health disparities. In the Hispanic American culture, they may rely strongly on family or religious leaders' advice over that of healthcare providers. They may be strongly matriarchal and live in multi-generational households. They may consult folk healers and believe in spiritual causes of illness. They highly value family connections and may be religious, commonly Catholic or Seventh-day Adventist. In the Asian American culture, they tend to place strong value on education. They may listen to health education as a sign of respect, but are unlikely to question or disagree due to respect for healthcare providers. They may believe that Western medicines impair balance in body systems and so use them for limited time or not at all. They also may decline testing, and they may strongly respect kinship and refer to elder family members or religious leaders for health advice. They may be religious, like Catholic, Buddhist, or Taoist. Then there's the Native American culture. There are over 550 distinct, unique, federally recognized tribes. They may listen to health education as a sign of respect, but they're unlikely to question or disagree due to the respect for the healthcare provider. They may believe that Western medicines impair the body systems and may prefer herbal medicines. They may view illness as punishment by spirits, and trust in the clinician is essential. They may strongly respect kinship and refer to elder family members or religious healers for health advice. And they may be religious, like Catholic or Protestant. In the Indo-American culture, they may be from India, Pakistan, Bangladesh, or Sri Lanka. They may listen to a healthcare provider as a sign of respect, but they're unlikely to question or disagree. They may believe in karma, family, and social order and prayer. They may believe that Western medicine system is one of multiple systems for healthcare and may feel illness is caused by imbalance or correction indicated. Holistic treatment, emphasizing prevention, is important, and they may strongly respect kinship and refer to elder family members or religious healers for health advice. They may be religious, like Hindu or Sikh. Religion must also be taken into account. Buddhists often are vegetarian. Karma is what they believe in, and suffering is inevitable. Meditation is important. Prevention is usually key, and they may refuse the medications that alter consciousness. and Taoists have qi or qi energy balance. They usually prefer acupuncture, coining, or cupping to restore balance, and certain foods have yin or yang energy. Sikhs are usually vegetarian with no alcohol or stimulants. And there's 5 symbols that are important to them: uncut hair, combing, sword, shorts, iron wristbands, and men cover their hair with a white wrap. Hindus are vegetarian with no beef or pork, and they do ritual cleansing. With Muslims, their modesty is very important, especially for females. So you usually have to have the same gender clinician. They do not use alcohol, and they have no pork and some other meats. They usually pray 4 times a day, and a holy day is on Friday. Daytime fasting for the month of Ramadan is very common. With Jehovah's Witnesses, they refuse whole blood and some blood tests. With Seventh-day Adventists, they're vegetarian, they do not use alcohol, tobacco, or caffeine, and their holy day is Saturday. In the Jewish faith, they may be kosher, and their holy day is Saturday. With Christians, they may refuse alcohol and may incorporate prayer into treatment, and their holy day is Sunday. So you can see in this basic religious overview, there is significant difference among those different types of religions. There are also other cultural groups. LGBTQS may refer to gender identity or sexual preference. Straight or cisgender M, whose sexual preference is W, or W who prefer M. Lesbians are women whose sexual preference is women, and gay is men whose sexual preference is men. Bisexual is men or women whose sexual preference may include men or women, and trans is men or women who have transitioned emotionally and or physically to the other gender. Queer questioning or uncertain is regarding gender identity and preferences. Two-spirit is Native American and others that may use this to indicate any LGBTQ preference. And the military may be socialized to be stoic about pain and suffering and may have difficulty raising questions and questioning authority. So there are many other cultural groups that may impact health disparities, implicit bias, and healthcare. So what do we do? What are some of the solutions? Here are some simple strategies to reduce implicit bias. First is stereotype replacement, recognizing that a response is based on stereotype and consciously adjusting the response. The second is counter-stereotypic imaging, imagining that without the stereotype, we're opposite of the stereotype. The third is individuation, seeing the person as an individual rather than a stereotype. For example, learning about their personal history and the context that brought them to the doctor's office or health center. A lot of clinicians use that one. The fourth is perspective taking, putting yourself in the other person's shoes. The fifth is increasing opportunities for contact with individuals from different groups, expanding one's network of friends and colleagues, or attending events where people of other racial and ethnic groups, gender identities, sexual orientation, and other groups may be present. And sixth, partnership building, reframing the interaction with individuals as one between collaborating equals rather than between a high status person and a low status person. Reframing interactions and partnership building may be the key to healthcare interacting with individuals and reducing implicit bias and healthcare disparities. Here are some more strategies to overcome unconscious bias. Cultural awareness involves the process of conducting a self-examination and critical reflection of one's own biases towards other cultures, and also our in-depth exploration of one's cultural background. You need to recognize stereotypical thinking and replace biases and assumptions. You need to understand the individual, explore a new perspective, increase opportunity for positive contact, and work to develop cultural humility, a dynamic and lifelong process focusing on self-reflection and personal critique. These are all strategies to overcome unconscious bias. Here are some personal strategies. Consciously affirm egalitarian goals and consider specific ways to implement them. Consider your gut reaction to someone as a potential indicator of implicit bias. Acknowledge and reappraise rather than suppressing uncomfortable feelings and thoughts. Next, consider a situation from an individual's or others' perspective. Self-reflect and provide feedback to improve clinical areas that might be inequitable. For example, include in evaluation feedback from the person. Or participate in research training efforts to reduce biases. And finally, consider strategies to change situations that increase negative responses. For example, information in other languages, or posters of LGBTQ families. Realizing that clinicians are people too, avoid bias in interactions with each other as well as with individuals, such as gender or generational bias. Affirm equity of care and diversity as a core organizational or institutional value wherever you work. One other key important element is health literacy and limited English proficiency. How does it impact healthcare diversity? The definition of health literacy is the ability to obtain, process, and understand basic health information and services needed to make appropriate health decisions. It occurs when giver and receiver are congruent. Reading, listening, and analytic healthcare decision-making skills in a healthcare setting occur, all surrounded within health literacy. So here's the estimated health literacy among adults in the United States. 12% are proficient in health literacy, and 53% have intermediate health literacy, while 22% only have basic health literacy, and 14% are below basic health literacy. That means around 36% of the individuals who are adults in the U.S. have difficulty with health literacy. And let's all admit it, a lot of us that are healthcare providers or clinicians often use our own language and make it more challenging for those that are not healthcare workers to understand what we're talking about. Health literacy is a stronger predictor of health status than age, race, education, employment status, and income level. Health literacy is linked to higher risk of death, more emergency room visits, and hospitalizations. In other words, health literacy impacts health status. Having poor health literacy is having less knowledge of your illness and treatment recommendations. People use preventive services less often, and they misuse the emergency department and have higher admission and readmission rates in the hospital. They have higher utilization and higher healthcare costs. They have poor health outcomes and experience stigma and shame. And they delay accessing care for several diseases or conditions. So poor health literacy has high impact. Some of the most vulnerable are elderly, over 65 years of age. 71% have difficulty with print materials, and 80% have difficulty using forms or charts, and 68% are interpreting numbers or performing calculations incorrectly. Other highly vulnerable groups include immigrant populations, minority populations, and low-income individuals. All are very vulnerable. However, all Medicare and Medicaid healthcare systems must provide interpreters. Individuals must be asked their preferred language and it must be used. Limited English proficiency individuals are less likely to use primary or preventive care services, more likely to use the emergency department. Women cite unavailable or inadequate translated materials are reason for declining cervical screening. And if they're asthmatic, they're less likely to keep appointments and take prescribed medications. Limited English proficiency impacts health status. So what is the solution to health equity? A framework with 5 key components for healthcare organizations to improve health equity in the communities they serve includes making health equity a strategic priority, developing structure and processes to support health equity work, deploying specific strategies to address the multiple determinants of health on which healthcare organizations can have a direct impact, decreasing institutional racism within their organization, and developing partnerships with community organizations to improve health equity. All of these are ways to improve health equity. There are significant disparities in life expectancy and other health outcomes that persist across the U.S. Healthcare has a significant role to play in achieving health equity. While healthcare organizations alone do not have the power to improve all of the multiple determinants of health for all of society, they do have the power to address disparities directly at the point of care and to impact many of the determinants that create these disparities. You can also evaluate your own implicit bias and test it. Harvard University Project Implicit has an online way to test yourself. Information on Project Implicit Bias is available at implicit.harvard.edu/implicit/. It's a 10-minute online survey to examine your own personal social attitudes. You log in and register and then you can find out if your implicit associations about race, gender, sexual orientation, and other topics exist. You can also find out your implicit associations about exercise, anxiety, alcohol eating, marijuana use, and other topics. So go ahead, test your implicit bias, and see what areas you might need to work on. It'll make you think about what thoughts did your results trigger, And you might take these results and impact your efforts to reduce implicit bias within healthcare for every individual you interact with and take care of. Thank you for listening to this continuing education event.